Good morning, everyone. My name is Chris Hanuscin. I'm one of the fourth-year residents, PGY 4s now. I'm going to be giving the first lecture of the year for the Ultrasound lecture series. Just a little plug, it's going to be a lecture series with 11 lectures focusing on bread and butter topics for ultrasound, but also throw in some advanced topics, some demonstrations, even procedures throughout the year. I'm on the team with Dr. JFK, Dr. Go, Dr. Murray, and Dr. Lee. So today I'm going to be giving a lecture on point of care echo. I know we do this every day, but I just want to go over the bread and butter of echo and then get into a little bit of the 60-60 rule. I'll tell you what that is a little bit later on. So the objectives for my lecture. So the objectives of my lecture, I want you to understand the indications why we do echoes in the emergency room, specifically why we do point of care echoes. We just have a specific answer that we want to, a specific question that we want to answer. I want you to know the four main views of point of care echo, understand the anatomy, why the anatomy is important of each of those views. We're going to go into a little bit about the 5 E's of pathology. And then again, at the very end, we're going to discuss the 60-60 rule, what it is, why we can use it. Okay, so some of the indications why we should be doing point of care echo in the emergency room. Like we know, we do it on most patients that come in for shortness of breath, chest pain, their vital signs, if they're tachycardic, if they're hypotensive, we do rush exams, if they had syncope, we look for some type of pathology. And then also during our traumas, we do fast exams, which include part of the echo, and then a cardiac arrest. We usually do our echo also. So the 4 views of echo, they kind of describe where you place your probe based on the name. We have the peristernal long axis view, then we have the peristernal short axis, and then you have your apical 4 chamber where you're getting all 4 with the chambers in the view to get a global assessment of the heart, and then you have your subside view, literally meaning underneath the subxiphoid process. So I'll go into each of those 4 views. All right, so for the peristernal long axis, you want to, or for the entire echo exam, you're going to be using your phase array probe, which is the smaller one. It has a smaller footprint, easier to get in between the ribs, but it has a wide view. So once it gets below those ribs, you can see a lot what's underneath them. So for the peristernal long axis, you want to place your probe around the 3rd or 4th rib space, right to the left of the peristernum, and have your probe marker. For ED docs, have your probe marker face towards their right shoulder. This is where you're going to get your best view. A little trick, especially initially trying to find the peristernal long axis, is just like moving your probe around in circles until you see something, and then once you see something, stop right there, then make minute movements, fanning and rocking from there. So this is the view that you should get in your peristernal long axis. As we all know, we see this view a lot. Just want to go over the anatomy a little bit. The wall at the very top, there's the RV3 wall, which will be important later when we talk about tamponade and fusions. Then you have your right ventricle towards the top, your right ventricular outflow tract, your aortic outflow tract, your left atrium, your left ventricle. It's very important to try to get this in an oblique, in a parallel view. Similar to this. A lot of times when we get it, it's the view is oblique, and which could alter your measurements, so also could make it hard to compare the right ventricle to the aortic outflow tract to the left ventricle. So it's very important to try to get it parallel with your screen. A good trick to do that is actually to rock your probe towards their right shoulder. So keep it in the same place, just rock your probe a little more. So this picture just shows you the view that you're getting with the ultrasound and how it compares to the actual anatomy. So you're cutting the heart in half from top to bottom to assess ejection fraction and other things that we'll go into. So this is what your view at the end should look like. And just a note too, try your hardest to try to get the descending aorta towards the bottom of your screen. That becomes important We'll talk about pathology. So try to just increase your depth to the point where you can get your descending aorta view. So now, next we'll go into the peristernal short access. So it's in the same exact location when you found your peristernal long access. Have your mitral valve right in the middle of the screen, and then all you do is rotate your probe down to the patient's right hip. So you don't have to move your probe at all. You may have to move it a little bit after you start to get your view, but really you're just rotating that probe marker towards the right hip. So this is what your view should look like. It's a cut of the heart towards the apex of the heart, and you're just trying to assess how the RV compares to the LV, and then concentric, or how concentric your LV is. You want to try to get down to the level of the papillary muscles. That's the standardized view, and I'll show you a little trick on how to get there. Go into anatomy a little bit. This is how, I know the probe marker is flipped on a lot of these images, but the way that they angle the probe in this one is the same as how our image would look. So you have your RV to the left of the screen, your interventricular septum to the middle, and then your LV to the right. Those two little polyp-looking things in the LV are your papillary muscles, and you want to try to get both of those into view. So this is what your view should look like, with both your papillary muscles and your septum. So most of the time, whatever's in the middle of your screen, when you rotate on that, that's just going to pop up after you rotate. So once we get our peristernal long, we're getting our mitral valve right in the middle of the screen. And then when we rotate, a lot of us will get an image like this with our mitral valve in the middle of our peristernal short. So a good trick to try to get down to the papillary muscles is either just slide towards the apex of the heart, down towards the nipple, or what you can also do is just fan down towards the nipple. And you can see it in this clip, that's what the ultrasound or ED doc did to get down to the papillary muscles. So they started off seeing the valve, and then they slid down and got the papillary muscles. So that should be an appropriate view. You shouldn't make an assessment based on a view with the mitral valve in the middle of your screen. Just another plug, I didn't know this really until this year. If you're having difficulty finding the peristernal short access, you can actually go to your subside view and then rotate the probe towards the head. And then instead of fanning towards the patient's right, where you would find their IVC, actually fan towards their left, and you can find the peristernal subside short axis view. So it would look something like this. Again, you're still looking for those papillary muscles, and you can still make the same assessment of how well the LV squeezes and how it compares to the RV. Next, we're going to talk about the Epico 4-chamber. So that's C in this diagram. You're going to place your probe marker below the nipple line on the left side. Have your probe marker facing towards their right. A good trick, I usually start around the nipple, and then as I move more medially. If I can't find it, I'll move laterally until I can find something. And if I start to get maybe one ventricle or one atrium into view, I'll hold my probe marker right there, and then actually just try to fan up towards the head or even down towards the feet. And eventually, when you start going back and forth, you'll get all four into view. A good trick is to try to get your septum straight down the middle. That's when your assessment will be most accurate. A lot of the times when we get our views, the septum is deviated towards the left. When you get that, just rock your probe out towards their arm, and it'll swing that septum straight down the middle. So just a little bit of anatomy. Again, the probe marker is split for a lot of these, but this is the same as we would see it on our screen. If you have the probe marker faced towards their right, you had your RV to the left of the screen, your RA to the left of the screen on the bottom, you have your LV top right, and your LA on the bottom right. This is again just showing the anatomy on the ultrasound, and this is what your clip should look like. This is the 4-chamber view. Sometimes in some patients' anatomy, you will get just a typical 5 view with the aortic valve in the middle. That's okay. You can still make the same assessments. If you only want the 4-chamber view based out of this, again, just fan a little bit towards the head. If you notice you're losing your view, actually try to go the opposite way. Just make very minute movements. And the last of our views is actually the subside. That's the B probe marker here. So you're going to place your probe marker still facing towards the patient's right. You put the probe directly below their subxiphoid process. A good trick, try to have your hand on top of the probe, not below, because you actually want to push down on the patient's abdomen and try to hook underneath their xiphoid process. You're going to be facing towards their left shoulder or even towards their head sometimes. If you're having trouble finding the heart, you can use the liver as a medium. Ultrasound waves like to go through dense organs, so it would actually augment the way your image looks. So because you're looking at the bottom of the heart now, looking up, so you would see your RV closest to your probe, on RV and RA, and then you would see towards the bottom of your screen, you actually see your left ventricle and left atrium. So this is the image that you would get from your subside process. This is just a clip of what you should see. This is just a normal subside image. And when you're here, what I started doing a lot of times with my echo is also getting assessment of your IVC. We'll go into like what that means later on. But how to obtain it from the subside process, you actually just rotate your probe towards the top of their head, and then start to angle more towards their right shoulder, and your IVC will come into play. A good way to distinguish if it's IVC versus aorta, you should see the vessel actually go into the heart, as you can see here, and you should see the hepatic vein empty into that vessel. That's how you know for sure that it's the IVC. If you're seeing the vessel go underneath the heart, not actually entering it, and you don't see the hepatic vein go into it, you are looking at the aorta. You're probably too far to the left side of the patient. Start fanning to the right. All right, so now that we know before views of ultrasound, their anatomy, we'll go into why they matter and what we're looking for. So we're going to go into the 5 E's of pathology of echo. This will just be a helpful reminder of what you're looking for if you remember what the 5 E's are. So first E is ejection fraction. So we want to assess what the patient's ejection fraction looks like. Do they have an effusion? Is that effusion worrisome? I'll show you some measurements that you can do. You want to assess quality. How does the RV compare to the LV? And then how do both of those also compare to the aortic outflow check? You want to assess their entrance, meaning their IVC. What does it look like? Is it plethoric? Is it collapsed? Does it look normal? And then you also want to assess their exit of the heart, the thoracic aorta. Is there dissection? Is there an aneurysm? Which we'll go over. So the first one is ejection fraction. So a good view to assess ejection fraction is actually looking at the peristernal long axis. You want to look at their mitral valve and see if it is hitting the interventricular septum. So as you can see, this is a normal clip. The valve is clearly hitting the septum, and there's a good overall squeeze of that left ventricle. Just a note, I see a lot of times people will see the heart going fast, and they'll be like, oh, it's hyperdynamic. A good way to tell between tachycardia and hyperdynamic left ventricular of the heart is the septum and the free wall actually touching. If they're kissing, then that's hyperdynamic. If it's just going fast, then that's just tachycardia. So this would be a normal ejection fraction. This clip here, as you can see, the valve is barely beating, it's flickering, it's nowhere near that septum. This would be a severely reduced EF. So this is easy to tell. The first one, we could see it hit the septum. This one we can't, so we know it's a reduced EF. Does anyone in the room know what to do if you can't tell if it's hitting the septum? MO looking for what type of measurement? EPSS, yeah. So the endpoint septal separation, which is you use the MO, the top of the screen there, you place your MO directly over the end of the mitral valve, and you're actually just measuring how far that distance it is from the septum. So what MO is just measurement on that line over time. And so we're the big thing that, at least for EPSS, is to see where the septum is and how close the valve gets to it. So at the bottom here, you can see where they measured like 18 millimeters is the E wave of the valve, the very tip. And then you're trying to see that distance to that middle line there, which is the septum. So here it's 18 millimeters. So anything below 5 is normal. Anything above 7 millimeters is a reduced EF, and anything above 10 is moderate to severely reduced EF. So it's a good trick. And we're going to go into how you can also use M mode later on to look for tamponade. So this is actually a clip of cardiac arrest. As you can see, you can kind of still see mitral valve movements, which arguably is this is still cardiac arrest. You don't see significant movements of the ventricular walls or the septum. You just see flicker of that valve, probably from the epinephrine that you give them. If the patient does not have a pulse and you see this, this is not considered cardiac activity. It's just flicker of the valve. So the next E in our 5 E's of pathology is effusions. We can use actually any of our views, any of our 4 views to assess for effusions. So to the left here is a parasternal long axis. You can see a pericardial effusion posterior to the heart. You can see it a little bit anterior. Just a note, because fluid is gravity dependent, you should see it towards the bottom of the heart first. If you're just seeing fluid towards the top of the heart and it's moving with that free wall, it's probably just a cardio fat pad and not an effusion. Just a little note for actually to determine if it's small, trace, small, moderate, or severe. You can measure it, and if the greatest part of the effusion is greater than 1 centimeter, it's a moderate effusion. And if it's greater than 2 centimeters, it's a large effusion. So to the left is the parasternal long axis, to the right is the parasternal short axis. You can see fluid around the heart. Those are both pretty big effusions. These next 2 clips is to the left is your apical 4 chamber view. You can see hypoechoic fluid around the heart here, and then to the right is your subside view. Your subside view is the most sensitive view to look for fluid, which is why it's included in our FAST exam. Just because, like I said, fluid is gravity dependent; it goes to the bottom of the heart, and with the subside, you're literally looking at the bottom of the heart. So, do any of the interns at home or here want to tell me how big this pericardial effusion is? Paul, what would you say how big is pericardial effusion?
Well, I can see in this top view of it, so but I can't really see posteriorly, but this doesn't give you the best view of that, so maybe moderate.
Moderate, okay. So it's kind of a trick question. There's actually just a very trace pericardial effusion here. That a lot of that black fluid that you see, the hypoechoic structure, is actually a pleural effusion. So that there's not much of a pericardial effusion here. It would be a trace. So this is why I said you should try to include your descending aorta into your views, because the way to tell if it's a pericardial or a pleural effusion is to see where it is relative to that descending aorta. So if it's anterior to the descending aorta, it's a pericardial effusion, but if it's posterior to the descending aorta, which it is here, that'd be a pleural effusion. And then determine, so people can have effusions, sometimes it's normal, sometimes it can be pathologic. What we really worry about with effusions is it causing tamponade? Is it causing RV collapse during diastole? So the heart should be filling during diastole, it should not be collapsing. So a good way to tell that, you can also just look at the heart and try to see, is that RV free wall collapsing when the valve is open, which is considered diastole. But a lot of times when the heart's moving fast, because they're tachycardic, and most of the time they're tachycardic when they're in tamponade, you can try to slow down your image to try to capture when that valve is open, or you can just use M mode. So the same way you were using UPSS, you're going to place your M mode over the mitral valve. You want to try to have your image completely perpendicular with the M mode to try to capture that RV free wall also. So the top line there that indents in is the movement of your RV free wall. And again, the sharp fin looking line is your mitral valve. So when that mitral valve is open, it's considered diastole. Your RV free wall should not be collapsing during diastole. In this image it is, so this is considered a sign of echocardiographic tamponade. Yeah. So this line here is your RV free wall movement. As you can see, it's the top of the mode here, so it correlates with this line. And this line here is very similar to your the line in your EPSS measurement is your opening and closing of the mitral valve. So when the valve goes up, like the shark fin, that means the valve is open. This free wall should stay straight or even bulge out because your RV is filling. So the fact that it's bulging in means it's collapsing due to the pressure from the fluid on the outside, and that's a sign of tamponade. All right, the next is the E of the 5 E's of pathology is equality. Just how does your RV look to your LV, and then also how does it compare to your aortic outflow tract? So here is just a normal parasternal long axis view. The ratio between your RV, aortic outflow tract, and LV should just be 1 to 1. As you can see in this image, this is a sign of increased right-sided pressures. Your RV is dramatically bigger than your LV here, and you can barely see the outflow tract because the RV is big. Here's a sign of septal bowing, the D sign. You can see the RV is much bigger than the LV here, and there's so much increased pressure that's actually causing that septum to bow into the left ventricle. This is a parasternal short image. This is a sign of some increased pressure on that left side, including a PE, which we're worried about. This is an apical 4-chamber view. Your RV should be about 1/3. It should be about 1/3 of your total image, and your LV should be the other 2/3. I remember it's similar to like the time you spend in diastole and systole. As you can see here, the RV is almost 2 times the size of the LV, and the RA is actually probably the biggest chamber in this view. That's all signs of right heart strain, and that's pathological. Next E is entrance. So this is looking at the IVC of going into the heart. So this is a normal IVC here. It should be around 2 centimeters. There may or may not be some respiratory variation. Most of the time there is. But if you see a very enlarged IVC with no respiratory variation, that's considered plethoric. So if you are worried about tamponade or any signs of obstructive or cardiogenic shock and you see this, you should be worried. That is a sign of shock or fluid overload. This is the IVC as it's collapsed. So you see it's not even 2 centimeters to start with, and then as they take a deep breath, it just fluid flows. The next and last E is actually the exit of the heart. So your thoracic aorta. You can also see this in the parasternal long axis view. So as you can see here, remember when we talked about how the RV, aortic outflow tract, and LV should all be about 1 to 1 to 1. You can see in the middle of the screen here, right where my mouth is, this huge aneurysm. This is the aortic outflow tract. It should not be this big. If you were to measure this, this is probably greater than 4.5 centimeters, which is considered to be abnormal. If you see a dilated outflow tract, that means the person is at risk for dissection. Just know that not all dissections are aneurysmal and not aneurysms dissect. They're just at risk for it. And speaking of dissections, this is actually a good view of someone that found a thoracic dissection. So as you can see here, they started in their parasternal long. They saw something that was a little abnormal, so they slid their probe marker further to the right to get a better image of the aorta. And you can see here this flap in the middle of the aorta. That should never be there. So this is a sign of dissection. Ultrasound isn't sensitive for dissections, meaning if you don't see it, don't stop your workup, still get the CTA. But if you do see it, it's highly specific. So if you see this, that means there is a dissection. You have your diagnosis. Get your consultant on board. Can anyone tell me where the pathology is in this image? I think we're still talking about exit, so think about the aorta.
So you're descending the aorta has a flatness.
Yep, so this is a sign of a type B dissection. There is a flap here in the descending aorta, right down the middle. that should not be there. Anything within the lumen of the descending aorta is a sign of dissection, so this should have you worried. Again, another plug that you should always try to get your descending aorta in your peritoneal long axis.
You can't tell if it's ARB, right?
Correct.
It's all descending.
Correct. This is just in the descending aorta, so you know it could be if there was no dissection anywhere else, but true. You can't tell if that's just B.
Would you say that the left heart chambers are also really dilated there?
Yes. Yeah, and the EF is reduced. All right. So now that you guys know your views, you know the pathology, the 5 E's of pathology, we're going to briefly talk about the 60-60 rule. So this is a very dense slide. Don't worry, I'm going to break it down. So the 60-60 rule sign can be used to look for acute PEs. It's very specific. It's actually 94% specific when they studied it. You can use it when you see signs of right heart strain, meaning if you have lab biomarkers, EKG changes, even other echo findings, McConnell sign, RV dilatation. If you see those things and you want to know if is this an acute process going on or a chronic process, and specifically is the acute process caused by a PE, you can use this rule. So it's actually 2 different measurements, and they both have to be below 60 for it to be suggestive of an acute PE. I'll go into what those measurements are. The reason that they'd be below 60 is that, as you can imagine, if there was chronic pulmonary hypertension, chronic PE, the heart would have some remodeling, and your pressures, your right ventricular systolic pressure will be increased above 60. So an acute PE won't cause it to be that elevated, so it should be below 60. So one measurement that you do want to get is your right ventricular systolic pressure, which is the left side of the screen, and I'll go into how to measure that. Also, I don't really understand the pathophysiology too much, but your pulmonary acceleration times will be increased in chronic processes due to changes in vascular compliance. So if you had an acute PE, your pulmonary acceleration time should be less than 60. So to calculate your right ventricular systolic pressure, it's actually 2 different measurements. You have to calculate your tricuspid gradient first, and then you add that to your right atrial pressure. And then you have to calculate your pulmonary acceleration time, which is just 1 measurement. So to calculate your right ventricular systolic pressure, I'll get back to the calculation. But you have to get your apical 4 chamber view. You need to have, in order to get this calculation, you need to have tricuspid regurg. So you should always assess for tricuspid regurg first by putting color Doppler over the right side of the heart, and you need to see that jet. So this blue here is a tricuspid regurg. You see that jet coming back through the valve. You need to see this to do the measurement. So if you don't see that, you can stop right there. This measurement won't work for you. So going back, you want to place your continuous Doppler. So there's a continuous and there's a pulse wave Doppler option on the ultrasound machine. For this one, you want to use your continuous Doppler. You want to place that right past the mitral valve and hit Doppler again, and you're going to get this measurement down here. To calculate the tricuspid gradient, you want to calculate your tricuspid regurg max, which is just measuring from the isoelectric line down to the bottom. Unfortunately, it doesn't stop there. Once you get your tricuspid gradient, you have to square that and then times that by 4.
Makes sense.
Yeah. Dr. Sinner wasn't talking about math, but I am. So again, you just look for your apical 4 view, and you get your measurement from there. So once you have your tricuspid gradients, you have to add that to your right atrial pressure to get your RV systolic pressure. So we use the IVC as a surrogate for your right atrial pressure. And just remember these 3 numbers, 3, 8, and 15. It's just, those are the numbers that were picked for the sign. So when your IVC should be around 2 centimeters. If it's less than 2 centimeters and still collapses greater than 50%, then your RA pressure is only 3. But if it's around 2 centimeters and it collapses appropriately, then your RA pressure is 8. And then, but if you have plethoric IVC, then your RA pressure would be 15. So what would you guys say this pressure would be? 15. Great. What would this pressure be? 3. Yeah. And what about this? Good. So just remember those 3 numbers, 15, 8, and 3. So after you get your right atrial pressure, you want to add that to your tricuspid gradient that you calculated at first, and those should be below 60. If it is below 60, that's suggestive of an acute PE. So for the last measurement, there's no math in this one. You're just calculating your pulmonary acceleration time. The hard part with this measurement is actually getting your view. This isn't one of our typical views. This is a view of the pulmonic valve. The way to find it is after you find your peristernal short view, you want to just either fan towards their right shoulder or just move one rib space up, and you should get a view that looks like this. Your tricuspid valve will be to the top left of the screen here, flickering over here, and then your pulmonic valve is right here, and your aortic valve will be in the middle. When you find this view here, you're looking for your pulmonic valve. You just want to place your pulse spike Doppler, so it looks more like this with the 2 parallel bars, and it's not the diamond-shaped one like the continuous wave Doppler was. So you want to place that right over the valve, and then hit Doppler again, and you're going to get this measurement here. You want to measure from the beginning of your spike down to the apex here. So from the beginning to how far it goes down here to the apex, just this distance here, and that's your pulmonary acceleration time. So if that's less than 60, again, then that's another sign for specific for an acute PE. So I know that was a lot. My take-home points here is just sauna all your cardiopulmonary complaints. Even if they're coming with dyspnea, with a history of COPD or a history of CHF, still ultrasound them because you never know what you're going to find. And throw your trauma and cardiac arrest patients in there. Just remember your 4 views, why they're important. Remember the anatomy of your 4 views. Always assess for the 5 E's of pathology in each of those views, and then consider using the 60-60 rule when you see signs of right heart strain to assess for an acute PE. Any questions?
Good. Great job.
Can you send it to 60?
Yeah. And thank you to Focus Atlas and Core Ultrasound. You guys saved my life. Make this lecture.